So we assumed that in the urban slums of Nairobi, that the biggest challenge to access care was affording it and the distance to the healthcare services. So we set up facilities with clinicians to provide free counseling and guidance to the patients from this community. We also provided free medication, and we set these clinics on dates that we thought were appropriate or good for people, convenient for people to come to these clinics. At the very beginning of this exercise, we saw a lot of interest from the community. After the people were sensitized about these clinics, they came in big numbers, and we were very excited that finally we had a solution for the community. But as weeks went by, we started seeing numbers that were coming to seek care in these facilities going down, and that was becoming a point of concern for us. And we wanted really what was happening. But it's time to begin from the beginning. And my name is Frederick, Wekesah, and I work at the African Population Health Research Center in Nairobi, but I conduct my research as part of the Julius Center in UMC Utrecht. Now, in trying to understand why the numbers were going down, we studied perception for risk. And what do we mean by perception? Do people really understand what they are suffering from? We also studied the understanding of the risk factors for cardiovascular diseases, in this case smoking, harmful consumption of alcohol, insufficient physical activity, and consumption of vegetables and fruits. And we were able to discover that there was a disconnect between how people understood how these risk factors were linked to issues like stroke and heart attacks, or even closer to issues like obesity, issues like hypertension, and issues like diabetes. So that was one of the biggest findings of our research at the very beginning. But we also understood that even among people who knew about these conditions, were also struggling to seek care, and we discovered there was an element of opportunity cost in this population. So people were more interested in seeking livelihoods than struggling with issues that they thought were not necessarily very closer to them. But the third issue was really among people who did not see the link between their work and the environment in which they live in with the conditions that they struggle with. Like the people who didn't feel like they were more at risk to suffer from these conditions. That was a third category that we saw in our research. And some of the conclusions we made is that empowering this population, giving them information about their risk for cardiovascular diseases, and actually providing them opportunities for livelihood and education would empower them to seek care to protect themselves from cardiovascular disease risk factors and ultimately improve the health care of this population.